you see the motion is not smooth.
And at rest. Weight loss and exercise, pain relievers, HA or steroid injections are commonly prescribed treatments. With severe conditions worsen dramatically. The joint spaces become far narrower, causing more rapid and severe destruction of the cartilage. The knee becomes inflamed and sore. Synovial fluid is decreased, increasing friction and pain during movement. Within the synovial membrane, destructive proteins are produced, which further degrade cartilage and soft tissue around the knee. Osteoclites continue to develop. Bone moves against bone, not cartilage. Mobility, activities of daily living, and quality of life are severely impacted. Treatment for severe OA is typically surgery by receiving a partial or total.
So this is the background of cartilages, right? Now we move to the next stage. What will damage the cartilage? If it is too much pressure or the cartilage or joint has been damaged. Now you see, as we grow older, we get more problem, right? Females has less bone density as compared to males. That is why at your age, it is very important that you drink milk or laban, right? You do some exercise, because once you will reach to 45 to 50 years, then there is hormonal changes and bone becomes very fast healing, right? So that is why osteoarthritis becomes more common in women, right? Obesity, overweight, whether men or women. If too much weight is there, right, then it will be a problem. Any joint injury, right, will cause problems. So these are the major reasons of osteoarthritis. Now, we forget about this part, we forget about this part. Now, so I need to understand how much is the degeneration. If the degeneration is faqat pain, I will ask for some painkillers, some exercises, but we will not do much. But if this is so bad that patient cannot pray, patient cannot go to the washroom, right? Then it is better to do the steroid injection. If that is not working, then we can have a surgery, right? So that is what usually it is done. So as compared to rheumatoid arthritis, which is inflammatory condition, osteoarthritis usually we start with simple paracetamol, right? Just to control the pain, then NSAID, then steroid, right? So it is less painful as compared to rheumatoid arthritis. The third very common disease is neither related to
gout.
It's a crystal deposition, right? So here we see how gout happens.
However, water cannot dissolve
that means uric acid may increase either if we are eating too much urine pyramid or kidney is not taking it. What do you think? Which food has more uric acid production? Urine
Under
pyramid?
excretion.
Basically, urines are DNA material, right? So, where DNA is more, the internal organ, viscera, pitta, is full of DNA, right? Well, there are small cells, nucleus, right? So, those patients who have gout, I will say, pitta amru, right? So, that is green vegetable, big cell, very small chromosome, right? So, fruit, vegetable have less, but animal, especially the viscera, has high, right? That is one. Now, so if somebody has high uric acid, either it is the person is eating a lot or the person has a kidney problem, right? So that is what you will see.
Mutations in membrane proteins in the kidney that transport uric acid, such as URAF1, can also cause hyperuricemia. URAF1, which is found on the membrane of cells that line the tubes which drain urine, can reabsorb uric acid and filtrate into the cell, which then sends uric acid back into the blood. Mutations that increase the activity of URAF1 and other uric acid transporters causes more uric acid to be reabsorbed back into the bloodstream, leading to hyperuricemia. Small clumps of uric acid crystals.
So now, for example, uric acid is acid. Acetyl salicylic acid, which is aspirin, is also acid, right? So if somebody has high uric acid and kidney is trying to remove it, and that person start taking aspirin. So now both uric acid and aspirin moves from the kidney at the same point, right? So aspirin, if it is more, then uric acid will have a competition, right? So increased aspirin will cause increased uric acid in the blood, right? Similarly, a very famous drug, thiazide diuretic, right? So thiazide diuretic, like you have seen, it reabsorbs uric acid, right? So that means it will increase uric acid. Somebody who has hypertension and hyperuricemia, I will not give him thiazide because it will cause gout, right? So certain drugs also causes. So now we have three possibilities. People who are eating food which has high uric acid, people who are taking medicine which will increase uric acid, people who have kidney problem will have increased uric acid, right? So if there is a uric acid increase, what happens?
As hyperuricemia continues. Despite the crystals being sharp, they do not directly cause pain. Trauma, such as stubbing one's toe, or sudden swings in uric acid concentration, for example caused by amino-enriched purines, can cause some of the crystals to dislodge. When large immune cells known as macrophages swallow up the crystals, they begin to release an inflammatory signal protein known as interleukin-1 beta, which recruits and activates other immune cells to the joint space. This is a natural built-in response, not an autoimmune response, as uric acid is usually released by dead or dying cells. Therefore, crystals of uric acid normally indicate infections that are killing cells, and therefore requires inflammation to kill the pathogens causing the infection. In gout, even though there is no infection, inflammation occurs anyways. Whenever there is inflammation, there is redness, swelling, and pain. Acute gout attacks can last for up to a week, but eventually subside. Oftentimes, the attacks happen at night, as lower temperatures decrease solubility and increase crystallization. Usually, the attacks occur on the foot, particularly the joint of the big toe, possibly because our feet have a lower temperature compared to the rest of the body, and because our feet are most likely to get injured, for example, by stubbing your toe, which releases crystals. If nothing is done to treat the hyperuricemia, more episodes of acute gout can occur, which could eventually lead to continuous or chronic gout. Tophi, which are large clumps of uric acid, can form which permanently damage
Now, so we know there are three diseases: rheumatoid arthritis, osteoarthritis, gout. All can cause joint pain. Right? Forget about diseases. A patient comes in and said, I have joint pain. Right? How do I know this is rheumatoid, osteo, or gout? Right? So, what are the minimum number of questions? One is site. What else?
Duration,
How duration will help us?
if they chronic or not.
So, osteoarthritis can be chronic, rheumatoid arthritis can be chronic, gout can also be chronic.
Yes.
Why this is important?
Because gout is an
Now, think about what is the main pathology in rheumatoid arthritis
inflammation.
and what is the main pathology in osteoarthritis? Degeneration. Right? If I am not moving, right? So inflammatory chemicals will be more in the joint. But if I am moving, blood flow will take the chemicals out. What do you think rheumatoid arthritis patient will have more pain when they are resting or more pain when they are walking?
What is pain?
And what happened in degeneration?
When they move.
The opposite, right? Because it is degenerated. If they rest, they feel better. If they walk,
Move.
so the most
More
important question is, what seems to make the pain worse? What seems to make the pain
Really?
better? Right?
Aggravation.
And I am asking this question so that I can differentiate an inflammation or a degeneration. Right? So the two questions, one is how many joints are involved? Right? So the answer can be only one or more than one. So if it is only one, we call it monoarthritis. We will come back to, right? So the term is, if patient comes to me with joint pain, the first question I will ask about,
When?
how many joints? Right? So if it is only one joint or more than one, right? So it's called as mono and
Poly.
poly, right? If it is mono, yani this is the problem.
Osteoarthritis.
I will first try to confirm, is it the problem of joint or is it the problem of surrounding structure? Right? So muscle can also cause pain here, which is not the joint. So if it is mono, my question will be, is it joint or not the joint? So we call it barra joint, extra articular. Articular, extra articular. Now how can I differentiate between pain is joint or pain is extra articular? Now this is my joint, right? If my muscle is the major problem, so when I move my hand, I am using my muscle. It will be very painful. But if I ask somebody else to move my hand, it will be less painful. But if it is the joint problem, whether patient moves the hand or somebody else moves the hand, both will be equally painful. So I will ask again. So you see the two questions, inflammation or not, joint or not. We ask what makes pain more, what makes pain better. Right? So that is the two things. So the three main questions that I ask and I make the diagnosis. Where is the pain? Mono or poly? If it is mono, is it inflammation, joint or not, right? If it is poly, whether it is inflammation or not, right? So the three main questions that will help me to the diagnosis. These are the three main questions. So I will ask first, is it single joint or multiple? If it is single joint, is it articular and extra articular? How I want to ask about it? What seems to make it worse? When you move your hand do you feel more pain?
Or
Or when
some-
I move my hand, somebody else moves your pain, you feel more. Right? When the pain is more, right? Active or passive. If that is the answer, then you ask about inflammation and not. How can I differentiate between inflammation or not? Right? But
Mention.
When there's an exercise, the pain would be closer, it would not be an inflammation. And when they do exercise and the pain is more, there is an inflammation.
so normally when we rest, بالليل or midday. So early morning, subah, when a patient wakes up, the inflammation is worse, right? So when patient wakes up, feels difficult to come out of the bed. The joints become very tight, right? So as far as morning stiffness, right? Morning stiffness. So that morning stiffness is usually more than nussa, right? So morning stiffness mumkin osteoarthritis, mumkin rheumatoid arthritis. But rheumatoid arthritis morning stiffness
More
again,
time.
more than nussa, right? So I ask about when you wake up early in the morning, do you feel tightness of the joint? Yes. For how? Right? So patient has mumkin rubasa. That is not
Osteoarthritis.
right?
Yes.
So this is the three-way question that we ask him to make a diagnosis. Now, keep that thing in mind, right? So I am a patient, I came in, Doctora, I have joint pain. What is your first question?
How many joints?
Yani yamin, the foot.
Okay. It's relief when you're working or when you are rest.
I will see the muscle of the joint.
So how? Question.
I will miss the joint. It is monoarticular or extra?
Right? Ow! When you are moving, it's too painful. When I am moving, it's too painful.
So it's
It's annoying, right? What is the last question? So how?
when you're walking or when you
Hey, doctor, I have hypertension and my blood pressure was not in control. So doctor gave me a medicine. I started it and then I have this problem.
which medicine?
This is something which increases urine formation.
Gout.
Why gout? Good. Why gout?
Because-
It's a single joint, right? It is intra-articular.
Medicine.
It is induced with thiazide diet, right? Another patient came in and said, Doctor, I have Rakaba, right? Rakaba.
Okay.
Single joint or multiple?
Yani, sometime yamin, sometime yasar.
So it's systemic.
System.
Rheumatoid arthritis.
So it is not mono, it is poly. Fakat, I said
Okay.
yamin or yasar.
Okay.
Okay.
Yeah.
Next question.
Uh,
So it is poly, that means
I will
what
move
what is the worst?
One or two joints.
what makes it
Worse or better?
right? Yani, darajat. If I go up and down,
Okay.
or Tarawih prayer,
Okay.
right?
So
You see, very easy, right?
Yes.
So why we are not thinking of rheumatoid arthritis? Because the patient is not saying it is increased by rest.
yeah.
Yes,
It is
it's
increased
moving.
by activity,
Yes.
right? So that makes the diagnosis. Now, if I am a smart doctor, I will not only make a diagnosis, right? Think about rheumatoid arthritis. Can I stop the degeneration? It's a normal aging process. So what I am interested in, how bad is the degeneration, right? So I will ask, can you use the washroom without pain? Right? So we can. But the issue is, first we wanted to find out how much is the effect on life. Right? So a person can do the washing, can
More.
do daily prayer, right? So can go to the parties with some pain. Then you say, okay, it will come, go. You try to reduce your weight, right? You do some muscular exercise, take some hubub, masakin, right? So things like that. But you explain to them, this will not be cured, right? It will gradually go bad if you do not exercise, if you do not
Weight
reduce
loss.
your weight, right? So these are the things that you have to do, right? So that is how. But at this stage, we are not interested in that. We are interested in when a joint pain comes in, I think of it's a monoarticular or a
Body.
polyarticular, right? One of the reason of monoarticular is that, right?
Okay.
Another reason of monoarticular pain is infection. So it's called septic arthritis, right? So now I am adding two more elements. If somebody comes with joint pain, your first question are not this. Your first question is it trauma or not?
Okay.
Right?
So,
Trauma or not,
Oh no.
right? So you ask about how it started. Okay? And in your mind it is trauma or not, right? So we say joint pain is traumatic joint pain, atraumatic joint, right? If all of this is related to atraumatic joint, right? Usually in children, when they come in and they say joint pain, right? So we ask about trauma first, because I'm thinking of fracture, I'm thinking of ligamental tear, right? If it is not trauma, then I think about this, right?
Okay.
So the last part is, you already know the answers, right? So the last part is this diagram. Now you see from the beginning. So we are saying, are the symptoms of joint pain mono or poly?
Poly.
That is the first thing.
Okay.
If it is mono, what I am asking next, is it extra-articular or articular? If it is peri-articular, not in the joint, right? Then you think of other diseases which we are not covering now, right? If it is monoarticular and it is dakhil article, then you ask about inflammation. If it is no inflammation, but it is mono, usually it is the beginning of osteoarthritis,
Osteoarthritis.
right? Which later on will also involve other joints. But if there is an inflammation and it is one joint, right? So then you ask about other features of gut. If it is there, you treat gut, right? Osteoarthritis at the beginning can be one, right? For example, if I am a right-footed person, right? So I will put more weight on my right leg. So initially my osteoarthritis will increase on the right side. But yes, yes, right? Now you see, so this half is monoarticular.
Okay.
If patient says I have this joint, this joint, this joint, right?
Polyarticular.
So it's a polyarticular. If it is polyarticular, you ask about for how long, right? Now, if I have a sore throat, many patients of corona complain of multiple small joint pain, right? So all viral illnesses causes a small joint of the hands arthritis, but it settles within 4 weeks, right? So if it is polyarticular, first thing I am interested in,
When did
it
it
is
start?
acute or chronic, right? So if it is acute, I think of any infection like sore throat or things like that. But if it is chronic, then I am interested in there is an inflammation or not. If it is chronic, if it is inflammation, what do you think of? Chronic inflammation, rheumatoid, right? So you think of rheumatoid arthritis, and then you think about the DMARDs, the biologics, etc. Right? So what are the 4 things we think about the diagnosis of rheumatoid arthritis? It should be chronic, joint, inflammation, serological findings, and chronic. Right? Any combination, it's not one thing alone. Any combination, the more the things are, the more chances rheumatoid arthritis. Right? So that makes our
Chronic
lecture
and
complete.
joint inflammation, serological, what is that?
Okay, joint, serology,
Chronic.
inflammation, chronic.
Chronic.
4 things. Right? So that is how you try to think from the joint diseases. Right? But Here we are talking about three different pathologies, right? One and the most important thing is inflammation. Now, if I ask you, now the disease is over, but the most important concept is you will always forget things if you do not understand the details of inflammation, right? So inflammation is something very good. Remember, in body, most of the part of the body has tissue with blood vessels. There are very few areas where there is a body part but there is no blood vessel. Like this part of the nose, like this part of the ear, there is no blood vessel. Right? So, a tissue with blood vessel. There are certain cells which are inside the blood vessels. They do not come out in the tissue, right? If there is any damage, if there is any injury, those cells will move from blood vessels outside in the tissue. That change is inflammation. So it's a response of vascular tissue against injury. That is the classic definition of inflammation. A response of vascular tissue against injury, in which there are inflammatory cells which move from blood vessels and move into the tissue. The first cell which moves out is neutrophil. Right? Neutrophil does what? Phagocytosis. When they phagocyte, when they eat something, they feel like we need more cells. So they release chemicals. These chemicals are called as chemotaxis or cytokines. Right? There are group of different cytokines. One group is called interleukins. Right? Inter is mabain. Leukin is WBC. Kin is harek. Right? So the word intermabain. So neutrophil is calling other white blood cells. Right? These chemicals are called as interleukins. So one interleukin 1, interleukin 2, interleukin 3, there are many. So interleukin 3 will go and call the macrophage, the another white blood cell, TAR. Right? So there will come in. Now macrophage is a major killer. Right? So then it will release other sets of inflammatory chemicals. Right? These chemicals will, the first change of these chemicals is blood vessel will become dilated. Right? When blood vessels dilate, fluid moves out of the blood vessel. So when fluid moves out of the blood, you feel swelling. Right? When there is too much red blood cell, white blood cell there, too much blood moving from there, it becomes hot. Right? So inflammation is diagnosed by pallor, change of color, rubor, redness, right? Tuber, swelling, and functional lisa. That means the body will be so much swollen, the body will not be able to work. Why this is all happening? Because of those chemotactic factors, because of those interleukins, right? How this comes? There is a fatty acid called as 20 carbon fatty acid. That fatty acid is broken down, and then there are two kinds of enzymes. Right? What are those? Cyclooxygenase and glycoxygenase. Right? So these makes thromboxanes, and then many chemicals are there. So if I block that enzyme, cyclooxygenase, right? The drug that blocks that enzyme is called as NSAID, right? Why it is called as non-steroidal? Because another chemical, another drug which can block these is steroid. So we have steroid or hydrosteroid. Steroid goes into the DNA and it blocks formation of protein. So it takes longer. Which one will act faster? Right? So that is why we call it, these are the two anti-inflammatory drugs. Right? So that is all about inflammation. Now, NSAID block an enzyme, but NSAID does not block both the enzymes. So still there will be some inflammation. So if I block the chemicals, then inflammation will not be that much. So based on that, we have biologics, DMARDs, right? These are all the drugs. So if you know the chemistry of inflammation, then it is very easy, right? So that's one beautiful video. Just write down the inflammatory mediators on YouTube, and you will see all. Then all of it will be very easy, right? 60 to 70% diseases are inflammation. So you need to have very good understanding of inflammation. That is the end of the lecture, right?
Thank you, doctor.
Have a nice day.
Thank you.